This is Tim, your Block 3 lecture instructor, and this voiceover PowerPoint is going to be on neuromuscular problems, specifically multiple sclerosis, myasthenia gravis, and Parkinson's disease. When you do your studying for these diseases, I want you to kind of keep a couple things in mind. One, these three diseases are their biggest problem is going to be safety. So you want to be able to teach your patient, whether it be in the hospital or at home, how to be as safe as possible. These diseases also will not get better, will not be cured, and the fact that you're really going to be fixing more of the symptoms than you are anything else. So keep those things in mind when we're going through these slides. All right, so first off, we're going to be doing multiple sclerosis. This is a disease that is very chronic. It is very progressive. It's not contagious. It is degenerative disease of the central nervous system. It is demyelinization of the neurons. This also happens to occur between the ages of 20 and 40 years old. Periods of remission and exacerbation. So you can have a patient who has multiple sclerosis, and there'll be days where they have really good times when they're actually able to get around or at least be stronger, and then there's going to be days when they're actually as weak as they possibly can be and can actually not move on their own. There are precipitating factors to cause this. It could be pregnancy, fatigue, stress, infection, and trauma. This is thought to be a result of autoimmune response or a viral infection. And I think I actually read somewhere that they believe that TB might actually, or at least having some contact with TB, could possibly cause this. Here's a picture of multiple sclerosis as far as the idea behind it. So it does affect the spinal cord, the spinal nerves. It's like I said, the demyelinization of the neurons, and those are actually found in the spinal nerve itself. Assessment-wise, we're looking at fatigue and weakness. You want to see how strong they are or how weak they are. You're also going to see ataxia and vertigo. You will also see tremors and spasticity of the lower extremities, possibly even paresthesia, blurred vision, diplopia, and transient blindness. You also have nystagmus, dysphagia, decreased perception of pain, touch, and temperature. So you want to actually make sure that you educate your patient and the family on the fact that they can't sense pain and heat and cold and extreme temperatures very well. So, drawing baths, you want to make sure that they're able to tolerate it, making sure they don't sleep with, heating pads or ice packs. Because they can't really sense these things, you want to make sure that they actually do all the precautions necessary so they don't get hurt. They will also possibly have bladder and bowel problems, such as urgency, frequency, retention, and incontinence. So I think bowel and bladder training is probably going to be necessary. It's also possible for these patients to have a suprapubic catheter because it's just a little bit easier. Other assessments is going to be abnormal reflexes, such as hyperreflexia. Absent reflexes, a positive Babinski reflex, which I show a picture here. There's also many emotional changes such as empathy, euphoria, irritability, and depression, memory changes, and confusion also. In order to diagnose this, they're going to do an EEG, which is an electroencephalographic test. They'll also possibly do a lumbar puncture. They will find in the lumbar puncture that there's an increased gamma globulin level and also serum globulin level. If it's normal, then it's possible that they actually have the MS also. Interventions. So provide energy-saving measures during times of exacerbation. So, teach your patient and their family to do things in clusters. If they're having a really good day and they do have a lot, some strength, do some of these activities or do any activities, whether it be walking or getting dressed or washing dishes. I mean, anything they can actually do as far as strength wise. But after they do these activities, then have them take a nap or have them sit and relax and try to regain their strength. You're also going to protect the patient from injury. Again, they can actually go from being, waking up and having a really good morning and having more strength than they had before. But once they start to get tired, then they'll start to get weaker. And they may get weaker faster than we can realize that they are. And again, you want to be as safe as possible. They can place an eye patch on the eye for diplopia that makes the other eye actually a little stronger and work a little bit better. Monitor for potential complications such as UTI, kidney stones, pressure ulcers, respiratory infections, and contractures. Again, patients that are having either an exacerbation or progressively getting worse, they start to, either lay on the couch or lay in bed longer than normal because of needing the rest and to be able to save their energy. So we have to remember to teach family members or even the patient that they need to turn every so often. You make sure that they're sitting up and not just completely laying down flat, and also doing some sort of range of motion exercises in bed. So that way it actually prevents contractures. Promote regular elimination by the bladder and bowel training. So again, you can actually, every couple hours, I don't say this to be mean, but it's just like kids, is it time to go to the bathroom? Sure. So, if you put on some sort of every 2 hour time schedule, it might actually get them more trained to be able to go at certain times and actually empty their bladder and their bowels. But you do also want to encourage independence. I think the more they can do on their own, the more they actually push themselves to do more, kind of keeps whatever strength that they do have and mobility and, it's almost if you don't use it, lose it type thing. So encouraging the independence allows them to, again, try to do as much as they can for as long as they can do it. Establish a regular exercise and rest program. Again, I think that, going to the gym and doing some sort of strength training or some sort of range of motion, and they don't have to get built. They just need to be able to keep the strength that they do have while they're able to do it. And then again, they can come home, take a nap, and get their rest. And then provide assistant devices such as walkers and canes and braces and crutches. I mean, whatever you need to do to be able to get them as mobile as possible. The last resort is to put them in some sort of wheelchair because, at that point they're going to be constantly sitting. They're more apt to actually get some sort of breakdown, and they're also going to get weak and the atrophy of their muscles. Interventions initiate speech and physical therapy because of the slurred speech. I think that the more training you can do while they have the ability to learn and do it, it kind of keeps what they have for as long as they possibly can. Avoid fatigue, stress, infection, overheating, and chilling. Regulate the bathwater temperature and avoid heating pads. I mentioned that before. Increase fluid intake. Make sure that they're getting enough to drink. The concept of, well, if I don't drink fluids, then I don't have to pee. Well, that it makes sense and it will work, but then you also get dehydrated and you also are more apt to getting UTIs. So you want them to actually drink as much as possible. Not only will it keep them hydrated, it also keep their urine flowing and also keep their bowels moving. You want to be able to keep their system as clean as possible. For meals, get a balanced meal with high fiber, low fat, and high potassium. Provide information on sports groups. Not only is the patient being cared for by family members, and they will do the best they possibly can to keep their family members as strong and as independent as possible, and keep them at home as much as possible. But in the same sense, too, those caregivers need help too and need somebody some sort of support from others who have actually been through it. The next one is Myasthenia gravis. It's a neuromuscular disease. It's characterized by considerable weakness and abnormal fatigue of the voluntary muscles. I have taken care of patients who have had myasthenia gravis before, and for me, I think it actually affects more of their respiratory and accessory muscles than anything else. So for them, they're needing more oxygen. They're not able to have the strength to be able to breathe. They are able to breathe on their own, but it does tire them out a lot. It is a defect in the transmission of nerve impulses at the myoneural junction. It's a lack of acetylcholine and an increased cholinesterase. It is unresponsiveness of the muscle fibers to the acetylcholine. Assessment-wise, you're going to have weakness and fatigue, you're going to have difficulty chewing, you're going to have dysphagia, ptosis, diplopia, weak, hoarse voice, difficulty breathing, diminished breath sounds, and respiratory failure and paralysis. So again, I think this is probably affecting more of the trunk of the body and the neck, and they are going to be weak in their extremities, but I think this is more of a trunk and neck issue as opposed to anywhere else. And again, the patients I've taken care of before, they've had more of the weak, hoarse voice, the difficulty breathing, the diminished breath sounds because they can't take those big, deep breaths. And those who I've actually taken care of, they have had this for a while, so it wasn't necessarily respiratory failure or paralysis, but they were there for an exacerbation of this disease. Interventions, you're going to monitor respiratory status and ability to cough and deep breathe adequately. If they can't cough and deep breathe, they're going to most likely end up getting some sort of either atelectasis or some sort of pneumonia. You're going to monitor for respiratory failure. Again, if these accessory muscles is what causes the patient to be able to instinctively inhale and exhale, and those start to get weak, eventually they're not going to be able to actually inhale and exhale, and that's what causes them to obviously suffocate. You monitor vital signs for blood pressure being too weak or heart rate being too high, or the fact that their O2 sats are not high enough. Monitor speech and swallowing to prevent aspiration. Sit up when eating. I believe you guys have learned this before. Aspiration precautions. Have them sit up as high as they possibly can. Purposely chew their food. Think about actually chewing it. Think about actually swallowing it. Tilting their chin to their chest. Things you do to make sure that they actually don't aspirate. Even a mechanical soft diet might even be something that they want to look into, whether it be at home. And a lot of these patients too, they also kind of know what they can and can't eat on their own. They might be able to eat chicken, but not be able to eat beef. It might be hard for them to chew one food as opposed to another, but it might be easier to swallow one food as opposed to the other. So a lot of these patients, they've had this long enough, they actually kind of, they're pretty independent. They kind of know their boundaries and their limitations. You want to assess their muscle status. You want to conserve their strength. Again, do an activity, take a nap. Do another activity, sit on the couch and kind of rest for a little bit. Plan activities that coincide with times of maximal muscle strength, and administer anticholinesterase medication. All right, so for a myasthenia crisis, this is acute exacerbation of the disease. It can be caused by progression of the disease or also infection, fatigue, stress, or not enough medication itself. Assessment-wise, you're looking at increased heart rate, respirations, and blood pressure. You're also looking at dyspnea and anoxia and cyanosis. You also will see decreased urine output, absence of cough, and swallow reflex. Again, this is the patients that their muscles are not working. I mean, they're extremely weak, and even things that are instinctively that we would do, like urinating and breathing and swallowing, those things will actually stop. Interventions are going to, again, increase the anticholinesterase medication. For a cholinergic crisis, this is too much anticholinesterase medication. You're going to see abdominal cramps, nausea, vomiting, diarrhea, blurred vision, pallor, facial muscle twitching, hypotension, pupillary miosis. Interventions are really going to be hold the medication and prepare an antidote, which is atropine sulfate. In order for a diagnosis, they'll do a Tensilon test. This is to diagnose myasthenia gravis. Endrophonium, which is also Tensilon, is injected and is administered to a patient. Positive for myasthenia gravis, improvement in the muscle strength after administration, and a negative myasthenia gravis is no improvement in the muscle strength at all. Usually they do this test when they've actually, the doctor will most likely know that they have myasthenia gravis. They do this really to prove that they're actually correct. The next disease process is Parkinson's disease. This is a degenerative disease caused by depletion of dopamine, which interferes with the inhibition of excitatory impulses, resulting in a dysfunction of the extrapyramidal system. So, for Parkinson's disease, this disease is slow, it's progressive, and it's also crippling. So they're going to start off with maybe a little bit of twitching, it's going to get worse over time, and then eventually it's going to they're going to be crippled to the point where they're not able to either live independently, do things independently, or they're going to need a lot of help. I think that the patients I've taken care of with this disease process, I think that the patients do as best as they can. The family members try to do as best as they can as far as taking care of their loved one. This is a very this is not a disease for inpatient people. And I say this because it takes a very long time for patients who have Parkinson's disease to be independent, to do things on their own. It takes a very long time for them to do it, and you just really have to sit back and let them do it on their own. They try to be as independent as much as possible. They try to be as strong as they possibly can until it gets to the point where the disease has progressed to the point where they can't do things on their own. So again, this is a combination of patient gets tired of being sick and tired, the family members get tired from taking care of those patients, and it just kind of snowballs. So you definitely need a lot of help and support with those who take care of a patient with Parkinson's disease. Going back to safety, and even with the other two disease processes, and specifically for this one, these patients have a higher risk of falls and hurting themselves. So I think safety is probably going to be the number one issue with these patients because of the fact that they have the tremors and it is hard for them to walk. They're more likely to actually get hurt than anybody else. So Parkinson's results in falls, deficit in self-care, failure of body systems, and depression. It also will cause mental deterioration, which will correlate in the actual disease. I didn't actually know this until I started seeing some of the disease, some of the commercials for the medications for Parkinson's, and one of the symptoms is the almost kind of like a dementia or Alzheimer's. They start to see things that aren't there. They start to believe things that didn't really happen. And I didn't really know that until I saw the commercials, but now that I've seen it, I believe that it is probably a pretty common occurrence. Assessment-wise, you're going to have the bradykinesia, you're going to have the akinesia, you're going to have the monotonous speech, handwriting becomes smaller. I put things in red because I think these are the most common symptoms that I have actually seen as a nurse. You're going to see the tremors in the hands and the fingers, such as the pill rolling. You'll see tremors increased with fatigue, decreases with purposeful activity or sleep. So patients who have these tremors, if you give them something and put it in their hand and make them purposely do something, those fine motor skills actually take over. They specifically think about what they're doing, and the tremors usually either become non-existent or they actually slow down to where the patient can purposely do something. You also see rigidity and jerky movement, blank facial expressions, the mask-like face. You also see drooling, difficulty swallowing and speaking, loss of coordination and balance, shuffling steps, stooped position, and the propulsive gait. So again, this is really more of keeping them as independent as possible, keeping them as strong as they possibly can, give them things that are very purposeful to keep the tremors down, and also, making sure that safety is number one. And again, these patients have a higher risk of falling than anybody else. Interventions, you're going to assess neurological status and the ability to swallow and chew. I put SP here, which is speech therapy. They're also going to do high calorie, high protein, high fiber, soft diet with small frequent feedings because of the difficulty swallowing and the fact that it does take them a very long time to actually eat. And it also tires them out. Do the small frequent meals. The high calorie, high protein, high fiber is going to allow them to get as many calories as they possibly can in a small amount of time. Also same with the protein, but then the high fiber will allow them to kind of keep their bowels moving. So increase fluid intake to 2,000 mLs a day. This is to keep them hydrated. You're going to monitor for constipation, so again, increase their fiber diet. Promote independence as long as they possibly can. PT and OT, physical therapy and occupational therapy will help you or help the family members and their patient as far as teaching them what to do to keep their strength up. Avoid rushing the patient with activities. Again, I've it's a very long, drawn out process for a patient with Parkinson's disease to do one thing. And I'm kind of guilty of being impatient, and I mean, and not noticeably impatient, but just you're thinking to yourself, "Gosh, just hurry up," or you really want to take over and do it for them, and that allows them to lose their independence and their strength, and it probably causes some sort of depression, and I wouldn't want to lose my independence either. So you really have to let them do things on their own. Assist with ambulation, provide assistant devices, encourage to lift feet when walking, because again they have the shuffling gait, promote proper posture, administer anti-Parkinsonian medication to increase the level of dopamine, avoid foods high in B6 because they block the effects of the medication. So for medication, this is the levodopa-carbidopa or Seniment. This combination of medication is used to treat symptoms of Parkinson's disease or Parkinson-like symptoms such as shakiness, stiffiness, difficulty moving. Parkinson's disease is thought to be caused by too little of naturally occurring substances such as dopamine in the brain. So levodopa changes into dopamine in the brain and then helping controlling their movement. Carbidopa actually prevents the breakdown of levodopa in the bloodstream so the levodopa can enter the brain itself. So the levodopa actually changes into the brain, it changes into dopamine in the brain, and the carbidopa is really just to allow it to stay in the system long enough for the symptoms to be subside. I will tell you that patients will start off on a low dose, and then as symptoms progressively get worse over time, they'll just keep increasing the dose until there's nothing left. So again, at some point, the shakiness will get worse. You'll give them the meds, it will go away, and eventually their body just gets used to it, and they have to increase the dosages. I usually have found patients to be taking this about 4 or 5 times a day. And it seems to work better. I also can tell you that I've seen patients that the levodopa or carbidopa is wearing off, and you can start to see that, Parkinson's symptoms, especially the tremors, and then you give them the meds and that actually comes down. So it's very interesting to be able to see that. So anyways, I think that's the last slide, and it is. So if you have any questions, let me know, and I will see you in class.